Everybody. It's a real pleasure to having you to the webinar of the EANS task force of the European Association of Neurosurgical Societies. Today we shall discuss a topic that is not exactly neurosurgical, but cover also something that is closely related to our job. We shall discuss peripheral nerve interface strategies to enhance function after limb loss. Of course, there are nerves, peripheral nerves, and something that I would say is more or less revolutionary. So we will have the Professor Paul Sederna, who will be our guest today to explain us a little bit how this field is evolving. We will have a lecture from his part, and after that we will have a discussion. I would like to ask all of you, if you have any questions during the lecture, please send them in the question and answer box and not in the chat, in the general chat, so we can have them for the end of the lecture and the discussion that will follow the lecture. But before starting, I would like to share with you some thoughts why we have decided to have this lecture. I saw this title, Walking Naturally After Spinal Cord Injury, using a brain-spinal interface. I saw this title, and I thought myself that probably this is a tabloid title, that it's not possible. All of us knows that it is not possible to walk hours after severe spinal cord injury. But no, it was an article in Nature. It was an article in Nature from a team from Switzerland. And in fact, this was a very sophisticated method to overcome and to bypass the spinal injury. And as you can see on this slide, there are cortical implants that are acquiring the signal from our motor cortex. They are analyzing this signal thanks to artificial intelligence, and they are sending this signal to some epidural implants, bypassing the lesion of the spinal cord. And the final result is that this patient can walk after 2 years of paraplegia and spinal cord injury. So I think that this is something completely revolutionary. Something else, we know that the investment in this field are growing and growing. Elon Musk have bought the company Neuralink, and nowadays Neuralink has an approval for human studies. This means that we have a lot of additional investment in this field, and we may expect to have a lot of news there. So let's say that we may expect a very interesting decade from this point of view. And that's why I'm sure that the other part, the peripheral part of this type of revolutionary innovations, and especially when we have lost a limb, how to enhance the function when we have lost a limb, is also a very important of all this framework of overcoming unsurmountable problems until very recently. So I would like to welcome Professor Sederna. He's very well known in the field of plastic surgery and in the field of enhancing the prosthesis, actually specific prosthesis. But please, for our auditorium, neurosurgical auditorium, Professor Sederna, please introduce yourself.
Thanks so much for that kind introduction, and thanks so much for the lead-in with the brain-machine interface work. So I'm Paul Sederna. It's great to be with you today. I'm really happy to be able to share a bunch of the work I've been doing. I'm Chief of Plastic Surgery here at the University of Michigan. We have 22 plastic surgeons on faculty. I run a big, busy lab. I have 20 people in my lab. We've had about $45 million in research funding over the years. I've published about 400 manuscripts to date. I've been president of the American Board of Plastic Surgery. I've been president of the American Society for Peripheral Nerve. I've been president of the Plastic Surgery Research Council. Anyway, all of that is to say that I work too much and I don't play enough, but I have learned some things about peripheral nerve interfacing and prosthetic control, so I'm excited to share all that with you. So I'm going to share my screen now, and
Thank you.
Now, can everyone see that okay?
Yes, it's perfect.
Great. Okay, well, let's go ahead and get started. So it has been over 40 years since Luke Skywalker got this prosthetic hand after he lost his hand to Darth Vader in Empire Strikes Back. And in that last 40 years, what have we actually accomplished? We even see in one of the Netflix series, Westworld, these prosthetic hands playing the piano, but they're really not prosthetic hands at all. They're actors with gloves on. And actually, what we really have is we have somebody supposedly playing a piano with their prosthetic hand, but they're just basically moving their hand up and down. I could do the same thing if I put just a stick in my mouth. And the problem with that is, like in the United States alone, we have 1.7 million people living with limb loss. There's 4 million people in Europe living with limb loss, 25 million people in Asia. So it is a huge number of people, and every single one of them is losing the ability to function like they normally did, to have good jobs, to take care of themselves, and they're really severely impacted. And what most people use is this hook. And the way this hook works is if you bring your arm out, this cable pulls. And when the cable pulls, the hook opens, and then a rubber band pulls it closed. The fact that most people are using a device like this is unbelievable to me in 2023. We just need to do better. So I have been working in the peripheral nerve space to control prosthetic devices. And the thing that's different about the peripheral nerve as opposed to the spinal cord or the brain are every single signal we need for efferent motor control is in the peripheral nervous system, with or without a limb, it's all there. So if I could connect up to the peripheral nerves, I could record their signals, I could feed that to a prosthesis, and I could control the prosthesis. Much, much easier than putting a probe in the brain and trying to delicately identify what's an index finger and what's a middle finger flexing when those areas are so tightly grouped inside the brain. And people have tried to do this in the peripheral nervous system for a long time. They've tried taking a cuff and wrapping a cuff around the peripheral nerve, or putting a sieve on the end of the peripheral nerve and having the nerves grow through this disc, or even using penetrating probes like this that they put into the nerve to try to pick up the peripheral nerve signals. The problem with all of this, and the reason this hasn't worked for so many years, is because it is so challenging to get small efferent motor action potentials out. And if we want to get a prosthesis to function like this, and then we want to put sensors on the end of the prosthesis and feed those sensations back for sensory afferent feedback, we need a better connection between the peripheral nervous system and our electronic system. And the issue is the efferent motor action potentials are tiny, and the electrical noise in the body is big. So the difference between an action potential and the electrical noise in the body is 1.2 or 1.3 bigger. So it's tiny. That means as soon as you start moving, or the electrode shifts a little, or there's a little bit of scarring that accumulates on the electrode, you stop being able to record signals from the nerve. And that's why we have never been able to do it. So that's where we have the room for innovation. That is where there's an opportunity to make a huge impact on the world by changing this. And so for us, rather than me trying to create a better peripheral nerve electrode, and people have tried to make them in all sorts of different materials and different configurations, instead, I decided I would develop a way to amplify the nerve signals so I don't need a better electrode, period. And the way I did that was by creating the regenerative peripheral nerve interface. And all that is you can take any peripheral nerve anywhere, open up the epineurium, and dissect the individual nerve fascicles out of the nerve. Then you can take small free skeletal muscle grafts, wrap them around each of the nerve fascicles. The muscle grafts survive the transfer. Each nerve fascicles reinnervates that small piece of muscle. And now, instead of trying to record tiny little efferent motor action potentials from a nerve, I can actually record small EMG signals from those small pieces of reinnervated muscle, the regenerative peripheral nerve interfaces. So now what happens, the efferent motor action potential comes down, it comes to the muscle, and I have a huge signal. Now I know exactly every single action potential coming through. I can even record individual motor units from individual nerves, so I can get really delicate control. So this is completely different than what anyone has done before. So what happens? Anytime you do anything new, everybody decides it's a horrible idea, particularly when you're changing the way people have thought about it for years. And so the first thing people are saying is, it's dead muscle. This is dead muscle. So why would it work? Well, I like dead muscle. I eat dead muscle. I like this dead muscle. I love it. I love it like sushi. I love it like steak. But this isn't dead muscle. So if we look at RPNIs 1 year after implantation, and we stain for neurofilament, we see beautiful axons coming down to neuromuscular junctions. We label alpha Bunger toxin, which labels motor end plates. We see beautiful motor end plates. And when we merge the two, we see these beautiful reinnervated muscles. So we know they get reinnervated and we know they're alive. Now, if I look at a median nerve RPNI, this is a patient that has no hand, and I just ask this patient to flex their thumb. FPL function, median nerve function, you can see RPNI number 1 contracting. The only way RPNI number 1 is contracting is that it is alive, it is reinnervated, and it's contracting. So now instead, I don't actually need to record a median nerve signal. I can just record that huge muscle signal from that small median nerve RPNI. And as you see, I have 4 median nerve RPNIs, so I can get 4 independent control signals from that median nerve with 4 different RPNIs. In the same patient, I asked them to flex their small finger, FDP to small finger. That is an ulnar nerve function. And you see that ulnar nerve RPNI contracting as he's flexing his small finger, even though he doesn't have a small finger. So this gives us evidence that they're all alive. So people then started talking about, well, you're really not going to be able to control a prosthesis with signals from an RPNI. So in this particular patient, they had an amputation at the level of their elbow. I did 2 radial nerve RPNIs, 4 median nerve RPNIs, and 3 ulnar nerve RPNIs. And here the patient is asked to just mimic the motion of my graduate student with their prosthetic thumb. And you can see how good his function is. The thumb actually gives you 50% of hand function, so having a thumb that moves like that is good. So that thumb moves like that because we have 4 independent control signals: FPL for thumb flexion, EPL for thumb extension, and median nerve intrinsic thumb function, and ulnar nerve intrinsic thumb function. That's what gives us that. Here he's going to turn a key, just like you or I would turn a key, turning your thumb in relation to your index finger.
Nice.
And it functions normally like a hand. Here you can see actually, he is just thinking about moving his thumb and index finger and controlling his prosthetic.
That's actually really cool.
The thing that's amazing about this is you couldn't get that function unless you interface directly with the peripheral nervous system. And in the past, you couldn't interface with the peripheral nervous system because the signals are too small. Now with RPNIs, the signals aren't too small at all. They get dramatically amplified, which gives us this amazing function. And here you can see he can move between individual grasp, like a fist grab, a pinch, a fist again. And he doesn't have to think about anything. He just moves exactly like he normally would.
1757.
So in the same way with brain interfacing, you could potentially do the same thing. The problem with brain interfacing is the signals are tiny in the brain as well. And everything is really close together. And so identifying individual finger function is very, very challenging. Having very broad functions to make people walk after a spinal cord injury, like we were just hearing about at the start of the talk, is amazing. And that's something I can't do with a peripheral nerve approach. But as we're thinking about reestablishing function for people with function lost due to spinal cord injuries or peripheral nerve injuries or amputations, we're going to need multiple different strategies for sure. So the next thing people said is, well, you can't control individual fingers with RPNIs. Well, the reality is we can control anything as long as we have a nerve that does the function, we can control that thing. And so here you can see the patient, and she's going to go through each of her functions.
Index. Pinky. Ring. Index. Middle. Thumb.
So this is just completely normal function like you or I would have. The problem, as you see with that prosthesis, is it does have all independent motors for the fingers, but it's a little bit slower. So it's not perfect. So there are lots of space to improve the quality of the prosthetics that patients are using. Here she is at a sandwich store. She just bought something to eat.
Yeah.
She's going to cut this muffin. It's a really hard muffin. We're going to have to get her a softer muffin the next time. The thing that's remarkable about this is that she was most impressed by the ability to grab the bag and carry it at her side. Because when she uses her body-powered hook, when she puts it at her side, it would open up and she would drop things. When she used her myoelectric prosthesis, the thing fires randomly and she would drop things. And so this, she was most happy just about being able to carry a bag. For me, I'm most happy that she has individual finger function, but for her, she is just happy to be able to carry something, which shows us how much improvement we need to make in the quality of function we can give people back who've lost a limb. So the other thing that you've all probably heard about is that older people don't regenerate their nerves very well. And a lot of older people have amputations. In the literature, what we know is, we know that axonal sprouting and axonal elongation occurs equally well in old people compared to young people. And there's a lot of nerve intact graft studies that have shown that. So this next patient, 75 years old, and we've done RPNIs on him. And now this is his first time controlling this prosthetic hand.
Nice.
I mean, that worked.
Yeah.
Pretty smooth.
And at 75 years old, there's no limit to his ability to do any of these tasks, like using a pinch and doing pronation, supination of his wrist. Or here you can see he's trying to open a jar with his hand. It's not working very well because the prosthetic hand's not that strong. He adjusts the position a little bit. It works better. And he adjusted a little bit more with his pronation, supination. Done. And this is 75 years old. So this tells us actually that even in older people, they're able to regenerate their nerves, regenerate their muscles, and reinnervate their muscles in the RPNI to give us this high level of function. And this is him just pouring like you or I would, grabbing and pouring. The next thing that's really important, one of the things that has been a barrier to brain-machine interfacing is the interfaces in the brain don't stay stable for very long. If you build up a little bit of scar tissue, a little bit of biofouling of an electrode in the brain, the signals disappear. If you do the same thing in a peripheral nerve, the signals disappear. Here, our signals are so big that we don't have problems long-term. So this is one of our patients who has been implanted for 1,300 days, and there has been no decrease in the size of her signals during that entire time. And if we look at the 4 humans we've implanted so far, our first one was 300 days and the signals are actually getting bigger. Our third patient, that signals are staying stable up to 400 days. Our next one, our signals are increasing at 300 days. And this patient at 1600 days, no change in the size of the RPNI signals. So what this tells us is this is an interface strategy that could be stable long-term. So for that patient that loses a limb because of a sarcoma or because of an amputation from trauma or whatever reason, we might be able to provide them a really strong peripheral nerve interface strategy to give them a good limb for the rest of their life. The other thing exciting about this is none of these patients required any recalibration of their system. And that's really important because the more difficult it is to use a device, the less likely someone is to use it. So that's been good. So the next thing I want to talk about is sensory feedback. So when we talked about using a muscle for sensory feedback, everyone said that's ridiculous and that doesn't make any sense. Because they talk about pure motor nerves innervate muscle. The reality is that pure motor nerves are 80 to 90% sensory afferents. There's so many afferents in the muscle that are innervating your Golgi tendon organs, your spindle cells, and all your sensory afferents of the muscle. And so actually using muscle for sensory feedback isn't a bad thing at all. And if we can provide sensory feedback for prosthetic users, it really will enable purposeful movement in people. Sensation is so necessary for performing activities of daily living, and it's really critical to have high-level functioning. And we do have some prosthetic devices that have sensors on the fingertips, so we can actually take electrical signals from sensors on fingertips, feed those back into the nerves, and then give people a sensate prosthetic limb. And so in one of our patients, she has 3 RPNIs in, 2 ulnar nerve RPNIs and 1 median nerve RPNI. One of her ulnar nerve RPNIs gives her sensation along the ulnar border of her hand. One of her ulnar nerve RPNIs gives her sensation on the tip of her ring finger. And one of her median nerve RPNIs give her sensation on her thumb. So somatotopically accurate. So in this series of experiments, what's happening is our student in the back is pressing on a sensorized hand, a hand that has sensors on it. We then stimulate the appropriate RPNI on her, and she is then going to point on the other student's hand where she's feeling it, okay? So he's pressing on the palm of her hand. We stimulate her median nerve RPNI. She feels it on the base of her thumb.
Stronger tingling right here.
He pushes on the ulnar border of her hand. We stimulate one of her ulnar nerve RPNIs.
Strong tingling over here.
She feels it on the ulnar border of her hand. We push on the end of her ring finger.
Slight tugging.
She feels it on the end of her ring finger. And it works every single time.
Slight tingling over here.
The other thing that happens is now we can actually, depending on how much we stimulate her median nerve and her ulnar nerve, we can actually fade her sensation across all the fingers of her hand, just like you fade sound in your car between your right speakers and your left speakers. We can do the same thing. We call it sensory steering, how we stimulate median nerve RPNIs and ulnar nerve RPNIs, so we can give sensation across all the fingers. So now let me explain this, because this is a little confusing. She is going to open and close her hand. She doesn't have a hand, but she's going to open and close her non-existent hand, okay? I know where her hand is in space because I'm recording her motor signals from her RPNIs. So I know where her hand is in space. I am then going to take a virtual object and put a virtual object in her virtual hand. And then when she's opening and closing her virtual hand, I'm going to give her sensory feedback, and she's going to tell us what object is in her hand. There's no hand, there's no object. But she's going to tell us what object, and she's going to do that all by how we give her sensory feedback. Are you with me? Opening and closing a non-existent hand, grabbing a non-existent object. I'm going to give her sensory feedback. She's going to tell us what she's feeling. And just a quick check. Are you hearing all the volume on the videos that have volume?
Yeah, it's
Great.
very
Okay, perfect. Okay, here we go.
It feels like it's probably big.
Yeah.
And I'm thinking it's the large can.
Yeah.
So she gets it, it's a large hand. So she closes her hand a little amount. She doesn't feel anything. But then when she gets to the size of the can, I start giving her sensory feedback. And when she tries to close more, I crank her sensory feedback up a lot so it feels hard. And then she knows, okay, big can. Okay. This is a squishy ball.
It's the small. Okay, probably it's the ball, the stress ball.
Uh-huh.
So in this one, she'll close her hand, feel nothing, 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 nothing. She'll get to here. I'll start giving her sensory feedback. And then as she tries to compress it, I'll slowly go up because it's compressible. So then she knows it's small and it's compressible.
It's not to say like you can squeeze it or anything, but when my fist gets to a certain, never gets to a smaller size, it pulsates. So I'm guessing that's the small can.
Okay.
Okay.
Maybe it's not the large can after all.
Oh, okay.
I'm gonna guess and say it's probably the bear.
Okay.
Because it's a wide grip,
Uh-huh.
but as I squeeze harder,
Yeah.
it's more a squeezable thing.
Uh-huh.
So she can actually feel all of these things that don't even exist based on how we provide her sensory feedback. So that means that actually we can program her to feel the world, every object, any object, and we can program it different. She may grab something that's different size. It may be big on top, small on the bottom. And I can program her so she can feel it's big up here and smaller down here. I mean, we can just program the world for her. So there's no limit to that, which is really exciting. And that's using muscle. And the interesting thing about muscle is, remember, the Golgi tendon organs and the spindles that reinnervate in the muscle go to her cerebellum, but the sensory afferents that go to her muscle go to actually her sensory cortex. So she gets both, brain and cerebellum, both. So that's one of the benefits of this. Now, there's just one other thing I want to talk about. Along the way of doing this for prosthetic control, we actually discovered that when patients have neuromas, we can cut out the neuromas and we can do a small RPNI in the end of the nerve. And then the nerve, when it grows into this denervated muscle, it'll grow in, it'll establish connections with the muscle, which we know and we've demonstrated. But then they don't develop recurrent neuromas, because as soon as the nerve reinnervates the muscle, it sends signals back, it prunes all of its other sprouting axons, it stops sprouting more, and it prevents neuromas from forming again. So in this study, we took a series of patients, and we either, at the time of their amputation, we either did prophylactic RPNIs at the time of their amputation, or we had their amputations managed like normal, with high ligation of the nerve or retraction and cutting, or burying the nerve in bone, burying it in muscle, capping it, any of the things that people do to nerves to try to prevent recurrent neuromas. So in this study, we had 45 patients that were in our prophylactic RPNI group. So that's RPNIs done at the time of amputation, and 45 in the control group that just had normal management of nerves at the time of amputation. And if you look across the board, we had 47 total operations in the prophylactic group and 50 in the control group. And the groups are upper limb amputations, lower limb amputations, everything. And you can see the nerves that we were doing the RPNIs on. They were pure motor nerves, pure sensory nerves, mixed nerves. They were upper limb, lower limb. They were even as proximal as the brachial plexus. So, and I did 159 RPNIs in this group. So lots and lots of RPNIs in these patients. So if we look in this group, on the y-axis is the percent of patients that had something. The yellow group is the control group, and the blue group is our prophylactic RPNI group. You can see all the way on the far right for all complications. For the control patients, 55% of them had a major complication. and in our group, only 30% did. So what we know is by taking a little extra time to do RPNIs during the operation, we are not increasing the complication rate at all. And if we look at the patients across the board, if we look at the number with symptomatic neuromas, at 1 year post-op, we already had 13% of the patients in the control group required another operation to address a recurrent neuroma, and we had 0 recurrent neuromas in the RPNI group. And we looked at phantom limb pain. 90% of the control group patients had phantom limb pain, and only 50% in our RPNI group had some degree of phantom limb pain. The phantom limb pain was significantly less frequent and less severe in that group. So what we know is RPNIs can provide amputees with an arm or a leg that moves like a normal arm or a leg. RPNIs can actually work very effectively to provide sensory feedback very, very well. And RPNIs can be used to treat neuroma pain, either existing neuroma pain and phantom limb pain, or prevent it. So I want to thank all the people that I work with here on our team, who are from departments of biomedical engineering, mechanical engineering, and kinesiology. My lab, a bunch of people in my lab now, 20 different people working with me of all varieties. More of my lab group and our funding sources. Lots and lots of work has gone into this. This particular work, we've gotten about $35 million worth of research funding to get us to where we are today. I really appreciate the opportunity to spend this time with you, and I'd be happy to answer any questions that anyone has about it. Thanks so much. I appreciate it.
Thank you very much, Professor. It was, first of all, congratulations for this spectacular, I would say, work that you have made. I think that we have a lot of questions for you, but I will start by presenting Dr. Ivanova. She's resident in plastic surgery in University Hospital Pirogov. She was very kind to put us in contact. So I would be glad to give her the opportunity to ask the first question for you.
Thank you. Hello, I hope you all hear me well. My Professor Gabrowski presented me right now. I want to thank him also for giving me the privilege of being a moderator, and to thank Professor Sederna for graciously accepting my invitation and joining us.
My pleasure.
Well, as I have already told him, for me, this is a groundbreaking level at which this is just the beginning, like the way you're using actually your amplification of the stable impulse. And this will be transcended in many places afterwards, not only in this domain, but many others, for me, at least. This is how I see the future. I was recently thinking of like what to ask you as a question, and I thought, like, from my practice and from what I've seen, for example, a patient with facial palsy, which is something that we have a lot, at least here in the country, because everybody's driving like crazy. So post-traumatic facial palsy, this is, this is a constant fight between the pathology and also actually, well, the work of surgeons and rehabilitators and the patient. And there's this balance that's nonstop restored and then again destabilized. This RPNI, like a system like this implanted somewhere around the facial nerve or to restore balance, would also be something in the future that I would like to see. So what do you think about this idea?
Yeah, thank you for the kind comments, and thank you for the question. So interestingly, it was probably 1995, John Faulkner and Bruce Carlson were actually using small free skeletal muscle grafts for facial paralysis when muscles were missing. And they were using them as free skeletal muscle grafts, and they worked. The only problem, to move the oral commissure, you need so much power. They weren't big enough and strong enough to move the oral commissure. So they worked great for blink, really well for blink and for smaller functions, but for bigger ones, they did not work. However, Doug Dow, who did his PhD in my lab, has used long-term electrical stimulation of muscle to maintain muscle bulk and mass and force. So we could actually use RPNIs on one side to pick up the facial nerve signals, feed them, and then electrically stimulate, appropriately to get symmetric facial function with implanted muscles. And so there's no question about it, that would definitely work. And there's no question about it. It's something we should do. There's so many things we should do. I wish we could start working on all of them simultaneously. And I wish I had a lab of 100 people. But yeah, that's a great idea, and I would love to do that. So thank you.
Yeah, and also there's a big amount of patients that are with limb loss, but even bigger, I checked, as for occurring with facial palsy.
Yep. Yep.
Yeah, this is also a problem for us as neurosurgeon. We're treating pontocerebral tumors of different kind. Frequently, we have this problem post-operatively, and this is a huge problem, especially for women particularly, but of course also for men, because it changed a lot the quality of life. So this definitely is a field that would be explored, and every advancement will be very useful for the patient. I see that Enrico have a question. Enrico?
Yes, thanks, Nikolai. And first of all, it was really impressive. Thanks a lot, Professor Sederna, for this presentation. And
thank you.
And I'm really impressed by the results. And I'm wondering, I mean, is there a perfect timing of RPNI after amputation, in the sense it is working better immediately after, or 6 months after amputation, or even many years after you can still implant your RPNI? And my second question is any nerve eligible for RPNI? Because I think that the nerve should be in a good shape before being reimplanted in a muscle. Thanks for your answers.
Yeah, so those are great questions. So we originally started doing RPNIs on people with existing neuroma pain and phantom limb pain who had had amputations in the past. And we did really, really well treating those. The one thing we didn't do as well on was phantom limb pain. And I think the longer someone has phantom limb pain, the more centralization of that pain you have, and the less impact a peripheral operation has on it centrally. And ultimately, actually, I think we may be thinking about doing DBS, deep brain stimulation, in some variety to address really severe phantom limb pain in the future. I don't think we're probably going to get at it through peripheral approaches. So by doing RPNIs at the time of amputation, if we can really limit the amount of phantom pain that they have and prevent the centralization, we probably have a better long-term outcome doing it at the time. And so that's my thought. We have a big grant right now we're doing functional MRIs. We're understanding the changes in the brain that we're making with these operations, both when we do them prophylactically and when we do them to treat pain. So we're going to have a much better understanding of that. We have a lot of patients enrolled so far, about 100 patients enrolled so far. So we're going to have answers coming up relatively soon. So for your second question, you're exactly right. We have to have healthy nerves for sure. So like in diabetic patients that have diabetic neuropathy, you just have to be proximal enough that the nerves you're working with are healthy nerves. But if they're doing an amputation, they're going to be coming up to the level where there's good blood supply, where it'll heal. So we should be in pretty good shape. But yeah, for sure. So for me, if I cut the nerve and I see a lot of scarring still in the nerve, like proximal to a neuroma, I go a little bit higher, or I go a little bit higher till I see really healthy looking nerve.
Okay, I see that we have a question from our auditorium. It's Christian Mutkov, who is asking, how does the patient control the amount of the applied force? Probably he means not only in the case where you have this feedback that you demonstrated, but if he don't have this feedback, how does he control the force of the movement?
Yep. So what we do is it's all based on amplitude. So just like me, if I close my finger really gently, I'm firing 1 or 2 motor units to do that. And that's why I'm closing slowly and gently, and I'm firing certain motor units. If I want to grab fast, or I'm going to grab something heavy, I fire all my motor units. So when we record their signals, because we have such high resolution of that muscle function, we can detect single motor unit. We can actually record recruitment of motor units with increasing force and speed, or all of them. So it's all related to the amplitude of the signal we're recording, and that's how we can get it. Now, of course, once we're giving sensory feedback, they'll be able to then tell how hard they're squeezing things, and that'll be really important in the process.
Okay, I see that we have one more question from Nicolas Sampon. Nico?
Hi, Nikolai. Thank you very much. Thank you, Professor Sardena. Was very impressive. Your lecture looks like we have a promising future. And so I would like you to comment on the interaction between the one field that is the brain-machine interface and the peripheral nerve connection. How do you see it? Is a kind of they are competing for the same function? They are complementary. How do you see the relationship between the two? And then lastly, how which will be the challenges of adoption? I mean, I think worldwide adoption of this amazing technology and techniques.
Yeah.
Thank you.
Yeah, thanks for those questions. Those are great questions. So I don't see brain machine interfacing and peripheral nerve interfacing as competing at all. I see them as complementary because there are some things I'm not going to be able to work on in the peripheral nervous system. So you have a high quadriplegic. We might be able to fit them with exoskeletons and give them brain signals to let them walk again and give them arms that let them drink. Giving somebody a hand back that does this with brain machine interfacing is going to be really, really hard. And that's a long, long, long ways away. And we're there now with the periphery. And so if somebody is 18 years old and they're able-bodied and they lost their arm in a motorcycle accident, a peripheral nerve strategy is a low-risk operation. It's going to give long-term stability and everything. We probably interface and give them a good hand that way. Spinal cord injured patient, I can't help them anyway because I don't have signals. So it's going to be a brain approach. And then some of them are going to be a mixture. And so I think they're complementary. And I love the approach. One of my very close collaborators, Cindy Chestek, her love and her passion is brain, and all her work is in the brain. And she has a monkey typing Shakespeare with eye tracking using her brain probes. But she also loves the periphery because there's stuff we can do in the periphery that can't be done in the brain and won't be done in the brain for a while, if ever. So I love both strategies. The second question, adoption. Yes. So RPNIs to control neuroma pain and phantom limb pain, easy. Anyone, anywhere can do it. You don't have to be a nerve surgeon. You don't have to be a microsurgeon. You don't have to be anything. The operations are really easy. So any surgeon of any variety, anywhere can do them. So adoption for that is going to be really easy. It's just them learning that it exists, and then they can help a lot of people. And that's one of the reasons I was actually lecturing this morning to a group of 35 Nigerian surgeons for that purpose. For prosthetic control, we'll need to get, I started a company that builds device. I didn't talk about any of my company or anything, but the device does all of the stuff, converts the signals, feed it wirelessly to the prosthesis and everything. We'll have to get that through the FDA. And once it's through the FDA, then we're good. Then it's just an issue of getting it reimbursed. And then people can get really high quality, advanced prosthetic devices that have individual fingers that move like a normal hand. So there are a few steps, but we're not that far away. It's very, very, very close.
I see that we have one more question from the auditorium. It's Antonio Barbieri, who is asking, is there any theoretical use of RPNI also in congenital amputees, maybe in early age?
Yeah, great answer. So it really depends. It depends why somebody doesn't have a limb. So if somebody had an amniotic band or a constriction band in utero, they actually have a normal limb with normal nerves, and we can interface with every one of those nerves and give them a hand back. If somebody has an embryologically undeveloped limb, they may not have all the nerves that we need. So what we would do in that case is we would use ultrasound to identify the nerves they have in their brachial plexus or in whatever limb they have. And then based upon what nerves they have, we could provide them that control. It just depends which nerves they had in that embryologically undeveloped limb. So it really just depends what nerves are there and what signals they're carrying, that's all. But we can figure that out preoperatively very easily.
Okay, thank you. Regarding that, we are getting close to the end of our session. I have a question for you. Do you have the feeling that we are close to some kind of revolutionary change in this field? Because I hate this word revolution when we talk about healthcare, about medicine. But what this title, with which I started the lecture, sounds revolutionary. What we saw today, what you demonstrate today, looks revolutionary. So I have the impression that something really big is very mature and will be part of our everyday in the forthcoming years.
Yeah, I thank you
Do
for
you
that
have this
comment.
impression?
Yeah, thank you for that comment. I agree with you 100%. There has been very little progress made in enhancing function for people with spinal cord injuries or limb loss for centuries. Hundreds of years, there's been very little progress. In the past 10 years, what I've seen in brain-machine interfacing, what I've seen in spinal cord injured patients, and what I'm seeing in my space, it is changing the world. And I think that has happened because physician scientists have gotten really involved in recent years, and physician scientists are now coming up with not just a new engineering solution that has a new special material or some special way of analyzing signals, but coming up with surgically based, biologically based solutions that are making a huge difference. So I agree with you. We are going to see a huge change, and there are going to be things happening in the upcoming years that we never dreamed of 20 years ago. And I think that's because surgeon scientists, physician scientists got involved, and it wasn't just engineers trying to solve an engineering problem in a biologic system.
It sounds really optimistic, so it sounds good for an end of our meeting. I would like to thank you very much, Professor Sedegna, for this outstanding presentation and talk. I would like to thanks also to Dr. Ivanova and Enrico, Nico. Thank you to all participants in this webinar. We will have our next webinar in 2 months' time. In the meanwhile, I would like just to remind you that the next EANS Congress will be in Sofia, so you are all more than welcome. The motto of the Congress will be Innovation, Education, Leadership. I think that what we saw today is perfectly shaped in 3 of them: in innovation, in education, in leadership that will change our tomorrow. So we have a lot of work to do, but we remain optimistic, and I'm very glad to hear that Professor Sedegna is also optimistic about the future. Have a good evening to all of you, and till our next webinar. Thank you very much.
Thanks so much. I really appreciate it. Bye-bye.
Thank you. Thank you.